Recording. And we will kick things off. So first of all, hi everyone. Congratulations on making it through Monday, and a special thank you to those of us who are joining from the East Coast. I know it's late, and obviously we really appreciate you taking the time. Thank you all for joining the first of what will really be a series of webinars exploring the role of the oral microbiome in advancing root cause oral health and care. For those of you who don't know me, my name is Danny Grannick. I'm the CEO and co-founder of Bristle Health. And for those of you who are new to the company, Bristle Health enables dental practices to provide comprehensive oral microbiome testing and care. Our test identifies and measures over 700 different bacteria and fungi, all from a single saliva sample, providing you with critical insights into oral health and disease to optimize and personalize your care. I am incredibly excited to introduce our two amazing hosts, Heather Kenney and Kriston Reisnour. So a bit of background on both of them. Heather has been practicing dental hygiene since 2005. She practiced in a ton of areas, including general private practice, CSOs, periodontology, and biologic and holistic-based practices. Heather currently enjoys practicing in a biological dental practice where she focuses her care on a functional and holistic approach. As a HIAOMT certified hygienist, she has gained knowledge on the oral microbiome through the use of phase contrast microscopy, salivary testing, along with studying the many aspects of disease processes in the mouth. Understanding the role of the oral microbiome, airway, nutrition, and gut health all play a role in oral systemic health and is really the foundation of her practice. Kriston passionately coaches dental teams on their role in today's integrated dental medical healthcare system. She is highly recommended in the dental profession, having been the dental program director for the Bale-Donin method and has extensive experience and knowledge in an integrated, comprehensive treatment planning approach. She is credentialed as a clinical sleep health educator, certified in orofacial mycology. She is an accredited biological hygienist and a fellow of the American Academy of Oral Systemic Health. Her work at the Seattle Study Club solidified her passion for developing academic educational programs for enhancing the oral systemic integrated process. She is an accomplished national speaker, a proficient author regularly featured in peer-reviewed publications, an instructor for the National Network of Health Hygienists, Cardiovascular and Chronic Inflammatory Cascade modules. She is the owner of Intentional Hygiene and Orofacial Mycology of PNW, an advisor for NNHH, an advisor at Bristle Health, and a board member for FAAOSH. She is licensed in 5 states and currently working as a clinical dental hygienist with over 34 years of experience in the beautiful state of Washington. You will find her ability to combine scientific depth and empathy both unique and refreshing. This webinar is packed with really valuable information. I'm excited to dive in. We're going to cover a bunch of important topics. Kriston, if you want to just hit to the next slide. There we go. So we are going to cover a bunch of topics, like I said. The first, discussing why the standard of care doesn't really address the root cause of oral and systemic disease pathways. We're going to explore how Bristle testing offers a comprehensive picture of the polymicrobial environment. And we're also going to learn about how polymicrobial dysbiosis can lead to chronic oral and systemic diseases. As part of this, we also want you to enhance your communication skills for not only recommending, but really leveraging and integrating oral microbiome testing into your practice and really being able to describe the benefits to patients. And I'm super excited for these. We're going to review some incredible case studies to understand in a very real sense how the results of oral microbiome testing can guide treatment planning and care. But before we begin, I just want to touch on a few housekeeping items. Out of respect for Heather and Kriston, please keep yourselves muted during the presentation. You can do that at the bottom left-hand corner of your screen. If you ever see that little square not having a cross through it, that means you're unmuted and everybody can hear your conversations or arguments or whatever might be going on in the background. If you have questions, you can submit them in writing. There's a little square at the bottom of your screen that says Q&A. And if there are any comments, you can throw them in the same place where we threw all of the places that you guys are calling in from. Additionally, if you guys can just keep your video cameras off. We want to make sure that Heather and Kriston really are at the top and available for any questions. And I also just wanted to specify that we will allocate time at the end to go through the Q&A. We won't be addressing them during the presentation. If there are any questions that we don't get to today, we'll follow up in writing, and we'll publish all of the different questions that you guys have. So I've definitely done enough talking. With that, we will let Kriston and Heather dive in. Thank you guys so much. And to everybody else, please enjoy.
Thank you, Danny. All right. Thanks everybody for joining us this evening. I'm Heather. I'm going to just ask a quick question. Mary, quite contrary, how does your garden grow? If you're not checking the fruits of your labor, do you really know? I know that's super cheesy, but I'm going to invite you into my garden process. My favorite pastime is enjoying the garden. So I really want to start our thought processes and mindsets that our oral microbiome and our patients, we really need to start considering them as the garden. So every spring, I start by planting the garden with making sure that I have good compost and I've replenished the soil from last year. I love going through the process of making sure that I put my plants in the right spot. I have the sun appropriately shining on my plants. And maybe I'm planting companion plants like nasturtium so that the bees come and pollinate my tomatoes. So as you can see here, this is my garden. It gets really full and fruitful. Our approach to our patients should be the same way. We need to make sure that we have a foundation for the soil and of their mouths to keep them healthy, and understand that we need to start companion planting, understanding the pH and the conditions so that we can provide the best fruit for our patients. And I want to start this evening really questioning, what is preventative dentistry? Is waiting for the disease processes preventative dentistry, or is it more reactionary? I want to walk through our current model of care with preventative dentistry. Right now, we evaluate the processes of disease. Periodontal evaluations involve charting missing teeth, probing depths and recession to help gather the clinical attachment loss that we may have in our patients. We should be incorporating that furcation involvement, making sure that we're doing our bleeding assessments and separation. And you should be really aware of where the mucogingival junction is, because that thick attachment is what keeps the bacterial load out of our patient's mucosal gingiva. So we categorize according to disease process. We're able to do a prophylaxis on our healthy patients, and our healthy patients are categorized as no bleeding, pink stipple furred tissue. We now have an amazing code, the 4346 code, that helps us with our gingivitis patients, but they're really only considered gingivitis at that 30% mark. And then, of course, periodontal disease are always within our maintenance processes and disease pathology. So is this truly preventative, or is it more reactive? I think our decay process is sort of the same way. During our treatment model for decay, we look at x-rays. Is there decay or isn't there decay? If there's decay, we treat and we fill and we drill, and maybe we're going to monitor. And in that process, maybe give some devices like fluoride treatments or maybe some hydroxyapatite, and really hope that we start to remineralize. But is this really addressing what's causing the disease? Are we throwing darts at the wall? Are our treatments really working? How are we assessing that to begin with? I just want to share where my story began. I started in functional dentistry using phase microscopy with a microscope. This was pretty amazing. I learned an immense amount, and it was super fun to share with my patients the worms that floated in their mouth and how that affected their oral health. I was able to look at inflammatory responses like this red blood cell that you can see here, but also assess if there was an inflammatory response by visualizing and showing them what white blood cells looked like as well. This was a really cool patient, lots of spirochetes swimming around, and this was just a gingivitis case. But I quickly learned that I wasn't really seeing the whole. So I started salivary testing. We need to start salivary testing and practice because it gives us a better understanding of the role of dysbiosis is taking place in our patients. It gives us true hints to the possible root causes of the pathways of disease. There are over 700 microbes, like Danny said, that can be unique to the oral microbiome. We've learned about these oral microbiome pathology through our classes in school, our microscope classes. And for decades, we've known the research that was shown that is correlated with oral disease and drives disease processes within the oral cavity and along with systemic disease. And we know that early detection and management of those pathology are helping to mitigate disease. But where does that fit in the clinical practice at this point? It hasn't. We really need to understand what dysbiosis is. And I think we've worked on dysbiosis for a long time by knowing that this imbalance within the community causes disease processes, including periodontal disease and decay. But are we really focusing on the dysbiosis, or should we be focusing more on creating homeostasis? And that's one of the things that I love about Bristle, is because we look at the whole entire picture and we really need to understand the benefits of the commensal bacteria and really stop thinking about bombing the mouth all the time. There are good bacteria within the mouth, and we need to understand that those bacteria help with the inflammatory response. And if you think about nitrates and nitric oxide, which is definitely a hot topic at this time with many professionals, that's like your nitrogen in the soil. It's going to help feed and promote a healthier environment and reduce your periodontal patients.
So let's talk a little bit about saliva, since it's the main key factor here. It's a kind of clear, slightly acidic biological fluid. And what's nice about it is it contains hormones, it contains growth factors, antibodies, enzymes, microbes, and their byproducts. And with that, it's mainly composed from our major salivary glands. We got the major and minor salivary glands. And it is a mirror of what's going on with our body, the health of our body. It's the nice thing about saliva, how it gets its blood flow. A lot of people say, well, how can you pull saliva out and know so much about the body? What happens is that salivary gland is surrounded by a lot of capillaries. The capillaries bring the blood in. The capillary through exosomes can carry material in the blood that shows like DNA and RNA from distant tumors from other organs. And it passes through this capillary into the salivary gland and out through the saliva, which is great because then we can kind of look for disease biomarkers and look for things that are happening, maybe prostate cancer, ovarian cancer, different types of cancers through the biomarkers. So we've come a long way. Saliva in the oral cavity, we're looking for caries, periodontitis, salivary gland diseases, and oral cancer, squamous cell cancer. Let me start again with that. Oral squamous cell carcinoma. We can find so many things. It's just so exciting that now we have saliva, which is actually the stepsister of blood. And then we come through to the systemic aspect of it, breast cancer, prostate cancers, ovarian cancers, viruses, HPV, hepatitis A, B, and C. And then pharmacologically, you can look for drugs within the system. So many things from a little drop of saliva. Salivary diagnostics has come on board, and it is the main thing that is bridging the dental and the medical, bringing them together once and for all, because we can look for things from the oral cavity, as far as what can happen, non-communicable diseases, autoimmune diseases such as Trojan's, dental caries, as we said, periodontal disease, and then the systemic conditions, cardiovascular disease, diabetes, infectious diseases, bacterioviral and fungal, all those things we can look for now within our patients. So it brings me to why Bristle. Why did I choose Bristle? I have been doing salivary testing for years. Love that aspect, to know a little bit more about my patients. But my mindset is I'm going to do the best I can until I know better. Bristle offered me more. I know that there's good and bad bacteria in the mouth. There's a balance. And if your immune system is not robust, what happens? That balance shifts. Those bacteria that are opportunistic take control, and they overpopulate. They push out your good bacteria. They even recruit some of those good bacteria into being bad. Bristle gives me the whole picture. I wanted to know more from my patients so that I can make optimal treatment decisions for them. With Bristle, with their testing, they do a shotgun approach. Basically, they're looking at the whole microbiome within that saliva test, what's going on in the whole saliva of your body, which is great because it's going to look for bacteria, fungi, viruses, and parasites. It looks for everything, and it breaks it down so you know what's actually the function of that bacteria, what's happening, how they interplaying together. Because then you can start to again say, oh, they have this particular bacteria and they have this one. What's happening? Why is the bad one high and the low one is low? What we need to look at the whole picture, because if we want to get balance, if we want to get total health, we can't do it unless we look at the whole picture. The other companies are again trying, and I am blessed to say that I'm happy they started this process, but they kind of look at basically snippets of DNA and RNA, and they kind of look at, well, are they present? Are they not? They don't give it the function of how they're actually working hand in hand together. Some only look for the 16S gene, and that's only looking at the bacteria. It doesn't even look at the viruses and fungi. We need to get a whole picture of what we're dealing with. It's like if you go to a medical doctor, you just get one test done, you don't know the whole picture, what's going on, you get treated for one thing. Well, that medication might affect another issue that's going on in your body. By having the whole picture, everything in that microbiome, you can be more comprehensive, have more insight in the oral health of that patient and any risks and conditions that are associated with that patient. With Bristle, the nice thing about Bristle is you're getting the whole 700. You're not getting 5, 11, or just a few. You're getting all 700 bacterial species are detected. Everything. You're getting candida. You're getting fungus. You're getting everything in one test. You don't have to do multiple tests to get the answer. One test is going to tell you everything that's going on with that patient. When we look at some of the dominant bacteria that are actually found, we know that strep mitis, these are the main 5 that are found commonly, and they can shape what's going on because one bacteria will change how another bacteria is behaving. It will either keep it in play or not. It will keep it down so it doesn't cause any damage, or it might let it do damage. But you need to know what are the main dominant bacteria in that saliva sample. Strep mitis, it's associated like say endocarditis, bacteremia, pneumonia, meningitis, and it's usually those are in the immunocompromised individuals. But it also can boost your immune system, so they can play dual roles. Just because you have good and bad doesn't mean that there's not a good part of that bad bacteria. Everything is working hand in hand if your immune system is robust and can keep everything balanced. All right. And it also, strep mitis can also kind of prevent the invasion of other oral pathogens. So it has a preventative measure to it too. Prevotella, it's common in a lot of like say synovial, it's like for vaginal and oral, other places. It's very common, but it's also found in the synovial fluids of those that have RA, and for those who have asthma as well. It's less likely to contain strep mutans if Prevotella is your dominant. Strep mutans causes caries, so it's kind of nice to find out who's the dominant player. And it kind of helps with decreasing the bacteria that cause halitosis, Klebsiella and that. So that's kind of nice as well. Actinomyces is commonly found in the oral microbiome. It kind of, that's the one bacteria that if you're going to find an infection after a dental treatment, actinomyces is the one that will actually flare up. It does cause endocarditis. It can, I said it can cause, I should say can cause endocarditis. So that's kind of the bad part. But then again, it also helps break down nitrates into nitrite, into nitric oxide, which is great for the vascular system and the oral health and even cognitive health. So it does have some positive too, as well as that. So you got to look at these bacteria and say, what's the good with the bad, and measure it and balance it. Neisseria also is a nitrate. It breaks down that nitrate into nitric oxide, which is again great for the vascular system, your total health. It also provides kind of breaks down into pneumonia, which is also well with metabolizing when it metabolizes amino acids, like for example arginine. And then you've got Neisseria. Is good to know if that's low, because if Neisseria is low and you have a pregnant woman, Neisseria is low, it's associated with low birth weight women, babies as well. So that is so very important to know. Now it has, now the more pathological side is gonorrhea and meningitis. So again, there's that flip side. Within every group, there are species, and then you have the subspecies and how they react. And then we have Rathia. Rathia is, you know, it produces enterobacter. It actually produces molecules that can stop the growth of pathogens, basically. And it's anti-inflammatory, and it also has that ability to break down nitrates into nitric oxide. All these bacteria have good and bad, but you want to know what's happening within that saliva sample. What's the abundant dominant, and then how does it affect everything else? In the other tests, we're not getting this information. We're just getting the bad bacteria, but we need to know the whole community and how the players are playing, and if they're basically playing nice in the sandbox. So the oral microbiome does affect the overall health. Some of you may have already read this article by Bradley Bell, Amy Doneen, and Dave Vigorous, and it's about high-risk periodontal pathogens contribute to the pathogenesis of atherosclerosis. Now, these particular doctors, cardiovascular, preventative, have set the stage for trying to get medical and dental to work hand in hand, because they realized they couldn't get the vascular health under control unless we got our oral health and our patients' oral health under control. They looked at studies that showed 5 high risk, FN, PG, AA, TF, and TD causes inflammation. It could break down the arterial wall. And that was a start, because that got us starting to think we need to look at the bacteria in the mouth and how it affects the rest of the body. I took those 5 high risk bacteria and I kind of broke them down when you look at this wonderful picture that depicts how much that bacteria in the mouth contributes to other health issues. Alzheimer's, the 5 high risk are there, but what I want you to really look at also is the other bacteria that are associated with it. We don't know what's going on with them when we just look at the 5 high risk. We know PG, that's a nasty little bugger. It can actually pass cell to cell and goes through the cranial nerves, can hijack white blood cells, T cells, and actually get through the bloodstream up to the brain, inflames the brain, causes amyloid plaque to be formed, which is inflammatory, causes neurodegenerative situations. And then it also produces gingipains, and gingipains actually are protein degrading enzymes. It's basically eating at the brain. So if we know that they have high PG, we want to get that under control. Cardiovascular disease, we've already talked about the 5 high risk, but what about PI, PN, PM, and EC? Diabetes, PI is also involved. Cancer, oral colorectal, we know AA, FN, PG, TD, TF, and PM. I want you to realize that you can swallow FN and it gets seated in the colon where inflammation is first started. And then you got that bacteria is where cancer will start. That's been proven. Pregnancy, we have to watch for pregnancy. Women in health, respiratory diseases and bacterial pneumonia, we all know that those bacteria are also associated in autoimmune disorders, as well as bone and joint. All these bacteria are not just the 5 high risk, but many, many bacteria play a role in the disease process. What about the health and microbiome effects on the baby? Well, here's a story, and many of you have heard me speak, have heard the story, and I just love it because it really speaks to the heart. Stacy Wu, at 39 weeks and 5 days, lost her little baby girl. Do you know at 39 weeks, you have already got that little crib made up. You've got that room all babyfied with baby stuff. She knew it was a girl, so you know it was just filled with little girl things. She was so excited to have her first baby. Well, 5 days before the baby was born, stillborn, she lost the baby. She had an upper respiratory tract infection. And you know that FN is one of those big players in those type of infections. Unfortunately, her immune system was pulled away from the oral cavity to the infection, trying to fight that lung infection. And that FN, being an opportunistic bacteria, passed that placenta and unfortunately multiplied and attacked that baby, which had no defenses. So she lost that baby to stillborn. She was devastated, wondering what she did wrong. Now, here's a woman who went in regularly for her dental visits. Her tissue bled, but we were so concerned with pregnancy hormone gingivitis that we didn't think anything of it. Oh, it's just, you know, pregnancy gingivitis, hormonal, it'll pass. Unfortunately, with this individual, and I'm pleading for all of you, when you have pregnant women, you have women who are thinking about getting pregnant, get tested. Set them up for success. Get a baseline for them, because we also know that they're going to have problems with airway. Airway is another component, as you're going to hear Heather will talk about the triad, that's going to cause those bacteria to overgrow. Get them set up for success so nobody goes through this heartache again. The good news is she did have a little baby boy and she learned from this, but what can we learn? Let's stop saying pregnancy gingivitis. Let's just say floss. Let's get these people tested so they can stay healthy and that baby has a chance to live a healthy life as well. So now we're moving on to the gut. The gut, because again, it's one tube from the top down all the way to the end. And we know that 70–80% of your immune system resides in that gut. So we want to know what's happening, because what happens when you're swallowing material, you're swallowing bacteria. Those single cells, epithelial cells, you see them lined up, they're held together by connective tissue. Just teeny little threads of connective tissue hold those little cells together. Inflammation starts to spread those cells apart. Inflammation will cause you to have zonulin. Zonulin also releases those little gaps, makes them bigger. So then what happens is more bacteria, their byproducts, toxins, all that gets into your bloodstream. What's going to happen? Your bloodstream's going to say, that doesn't belong here. Toll-like receptors, everything is going to go afire. And your inflammatory system is going to attack what's ever going on in that bloodstream. You're going to have malnutrition. You're not going to take on the vitamins that you normally do, as far as K, B's, D's. Nothing's going to be absorbed. So you're going to have issues with irritable bowel syndrome. Autoimmunity. It's another question that me and Heather were talking about, how periodontal disease is considered an autoimmune disease. It starts to eat away its own bone. Food intolerances like gluten. Then you realize that gut bacteria, they talk to each other through the mucosa. So you have the blood-brain barrier breach. And then systemic inflammation. Chronic systemic inflammation leads to chronic disease. Chronic disease leads to poor quality of life and, unfortunately, premature death. And this just says, again, if you have irritable bowel syndrome and that you are not actually taking in all the vitamins and the nourishment that you need, and you are deficient in these vitamins. Vitamin D, just to let you know, trickles down to every single body system. When I first got to Washington State, I was doing everything that I tell my patients to do. And I noticed my gums were bleeding. I said to the doctor, look at my gums. He goes, are you flossing? I couldn't believe it. I said, of course I'm flossing. So I did what I told my patients to do. I went for blood workup. severe vitamin D deficient. They put me on 50,000 units for 8 weeks. Make sure that you check these and send your patients off for getting these vitamins checked, because that's going to help with your whole diet part of your triad. Again, Fusobacterium nucleatum, that actually passes through into that gut, gets seated in that colon, and will cause cancer. All of these diseases have a direct link to the gut microbiome. As you're swallowing those bacteria, an overgrowth of bacteria in the mouth is an overgrowth of bacteria in the gut. Depression, again, it's 90% of serotonin and 50% of dopamine is made in the gut. Very important to know when you have those patients that have gut issues, because we know bacteria is causing it, how those bacteria are breaking down the epithelial lining, causing inflammation, and where the serotonin and dopamine actually levels are. Can they make enough? Look at the whole picture.
All right. Thank you so much, Kriston. Let's just talk about the factors of oral health and kind of put all of that together. Diet, oral dysbiosis, and airway are huge factors within the oral microbiome that can affect your scores. So oral dysbiosis, as we swallow that Fusobacterium nucleatum, it can cause some, gut disruptions. Fusobacterium is probably one of the number one bacteria that I see in the oral microbiome testing as an oral health coach. It's always one of the bacteria that I see at the highest level. So it is something that we really need to truly focus on. When we have oral dysbiosis, it can cause our gut dysbiosis. And that's why Bristle has a gum inflammation score, a gut inflammation score, or gut impact score. We also look at the commensals. We look at the nitrate levels. Why is nitrate important? Like I said before, nitrate is like your nitrogen in your garden. It's going to help promote the healthy bacteria. It's going to drive down inflammation. It's highly important for your vascular health. Are you checking salivary pH? pH is super important. If you don't have enough saliva in the mouth, you may have issues with decay problems. So once again, checking your pH level can help regulate and make sure that your patients have a good buffer system. I'm checking pH in my practice, and I try to teach patients to use products that will help boost your pH level. It's important to make sure our patients are at 6 or above. At that 6 mark, when you're below 6 at pH, you're going to have a demineralization process. So that's super important. So that's another factor for decay issues. And are we truly assessing, or are you assessing pH in practice? The other factors that we really need to consider is mouth breathing and airway issues. Those can be driving that dry mouth factor as well, which drives up inflammation, creates an environment for bacteria like Candida albicans. I learned through the oral microbiome testing and through my microscope that Candida albicans can be a significant factor with decay, especially your root line, your root decay, patients. Having Candida albicans on my slides, we ended up putting it with Bristle into the decay category, because I was noticing that if I saw my dry mouth patients who usually have some airway issues, they're going to drive up their inflammation, and usually Candida was involved in that process. And vitamin deficiencies. Are the vitamin deficiencies driving our decay and our bone loss processes? Are those vitamin deficiencies due to the pathology that can impact the gut inflammation, cause that leaky gut? So these are the factors that we need to start looking at as we're evaluating our garden and getting the soil ready. So we're going to go to the next slide. Awesome. Perfect. So I'm going to invite you all to start really doing integrative treatment processes, not just scaling and root planing, not just looking at, a healthy mouth or gingivitis, but really investigating what the root cause is that's causing the inflammations for your patients. Start pH testing in the office. There's strips that you can use for pH and nitrates to really assess whether the patient is producing nitric oxide. Are you doing a food diary to understand where the gut health is? Do they have food sensitivities? or IBS issues or SIBO problems. Those patients are going to have some major issues with cavity issues, and their vitamin D levels are going to be low. If vitamin D carries calcium, K2 lays it into the structures. Vitamins are an essential part of oral health, and we need to understand the dietary factors and where those deficiencies are coming from. I also want to make sure that we're looking at the airway aspects. Myofunctional therapy is a great way to help people with dry mouth issues, make sure they're breathing. Sleep apnea is a huge side effect of myofunctional dysfunction. And then, of course, we want to make sure that we're looking at the cardiovascular, the glucose levels. We always want to do the operative stuff where we're restoring restorations. We know restorations can be a huge cause for inflammation. So I just want to say, use gentle antimicrobials. Try to find something that's going to be more of a target towards your bacteria or your pathology. Pathology in the mouth, and Bristle gives us a really great insight to the pathology by tagging whether it's facultative or anaerobic. Bacteria that are anaerobic, oxygen is a great option. Making sure that you're using oxygenating processes like ozone or hydrogen peroxide is more targeting than adding in certain products that will just bomb the mouth. And then we need to really nourish the oral microbiome. We can nourish the oral microbiome through oral probiotics. I know this is sort of a new process and thought process, but going back to the garden, my garden won't grow unless I put seeds in it. So these may not be natural seeds in the oral microbiome. Lactobacillus rudii doesn't naturally rest in the mouth. However, we know that it improves immunity and it helps to kill the bacteria that may cause bad breath or gum inflammation. Lactobacillus salivarius, it fights bacteria like strep mutans. And so it can reduce your caries risk. And then same thing with some of the other Streptococcus strands that are beneficial. Really making sure that you are focusing on nourishing helps our, so I just want to share this part here. I brought this in because Bristle gives you many different aspects when it comes to looking at our testing score. We can tell you that Prevotella, Enterobacter, and Fusobacterium are sensitive to Lactobacillus rudii. What does that mean? It acts as a bactericidin. It acts as a corrector for those pathology within the mouth. So this tag gives you a couple different ideas. How the cell wall is. It's gram-negative or gram-positive. That can help you steer into the direction of what type of antimicrobials you use on, the actionability of the wall. We also show you the aerobic or facultative or anaerobic characteristics. This helps you to pick products that are going to be specific to bacteria. And then also incorporating those good seeds so that we can increase the commensals. It's really, really important to understand the commensals. These are our companion plants. We don't reach homeostasis within the oral microbiome unless we're focusing on increasing our diversity to a healthy level. Increasing the diversity usually leads to increasing the commensals. The commensals are our companion plants. Raffia, Nasaria are really good at that nitric oxide reduction process. And you'll always find that if we increase our commensals, we're going to have a better reduction of our inflammatory scores.
So who should be tested? The best way to look at it, I believe everybody should be tested. You can test the baseline for your new and existing patients. Look at your medical histories. If those who have comorbidities or systemic inflammatory conditions, or even if they have a family history of those inflammatory conditions, history of cancer, family history of cancer, pregnancy, like we just got done saying, set them up for success. Anybody that has an airway or breathing issue, when you're not breathing through your nose, you're not making that nitric oxide. You're going to dry that oral cavity out. You're going to have an overgrowth of bacteria. You're going to have more decay, more gum disease. And unfortunately, you're going to breathe those bacteria down and possibly have some upper airway issues as well. And as far as lung issues, bleeding gums, halitosis, burning mouth syndrome, those individuals who've complained about that in the past, again, by looking at your existing patient load and looking at some of their medical histories, start off in the morning and say, I'm going to pick 3 or 4 of these patients and present this to them as you're first starting out. Decay or ongoing through restorative treatment, braces, extractions, root canals, or any implants. The same bacteria that cause a person to lose their tooth is the same bacteria that will help cause them to lose an implant as well. So you want to set them up for success if they're going to be putting that type of restorative amount of money into their mouth as well. So it starts with the medical history, and you've all heard me say that many things start with the medical history. You have that right in your hand before you even see that patient. Again, look for the cardiovascular issues. Any issues that are inflammatory cardiovascular wise, you know that they can't afford to have inflammation in their mouth. Strokes, vascular disease, erectile dysfunction. Erectile dysfunction is a microvessel atherosclerotic process in and of itself. Any diabetes, you know that biodirectional relationship, blood pressures. They come in, you take their blood pressure and it's high, and you already know they're taking 1 blood pressure medication, maybe 2. Start thinking of drug-resistant hypertension, sleep apnea, and airway issue. Moving on to the airway issues, ammonia, asthma, or if they had a history when they were a child of bronchitis, those are all airway issues. Acid reflux or silent acid reflux. When you look at those teeth and you see that they have erosion on them, start to think of that's the process of not being able to breathe properly and bringing the stomach acids up when you're trying to. Headaches, especially morning headaches, lack of oxygen. That's from not breathing properly in the nighttime, sleep apnea. But again, all of these conditions will lead to inflammation. Inflammation leads to chronic disease. PTSD, depression, not only the gut, serotonin, dopamine, those feel goods, maybe they're not getting enough oxygen that are released in certain hormones and steroids and things like that. Medications, look at their medications. You can tell so much more about the medications. And don't forget to ask, because a lot of them will not put everything on it. If you see some on there, know that there's an issue you need to address. Don't hesitate to talk about the diet and the drinking history as well. All of these are inflammatory conditions that are associated with inflammation. That doesn't mean this comes from the Baldonine method. This does not mean that a person's going to have a vascular event, but these are different things that you can find on your medical history that's going to tell you that that immune system is not where it needs to be. It's fighting other conditions. So can it truly put its full attention in the oral cavity? No, it can't. So you're going to have that balance is going to start to shift. And the balance will shift depending on what that patient's going through at the time. So now we get to have some fun. Now we're going to review some patient cases and some examples. And Heather's going to do a beautiful job with this patient because we're always trying to find an answer. And sometimes it's not as obvious as you would think.
All right, I'm super excited to be presenting this case this evening. So we've talked about all of the typical pathology that we've learned through our oral microbiome and microbiology classes, right? That are the drivers of inflammation. But I love Bristle because we get to look at different pathology and sort of get a better idea of what might be driving inflammation. So we have an unusual suspect we'll be dealing with this evening. And this is sort of a new pathology to start considering. And I'm going to tell a story about the process of his journey, this patient's journey in resolving the issue. So serratia marsans, what the heck is that? Have we ever heard of that one before? And do we know what it causes in the mouth? All right, so I'm going to remind you that we have all of these patients in our chair. I started in perio, and time after time again, we had those patients that are saying, I have meticulous home care. I'm brushing, I'm flossing, I'm doing what I'm supposed to, but they're still in that cascade of inflammation. This is a 40-year-old male. He doesn't appear to have any major medical issues. He's not taking any medications. They're monitoring his glucose levels because he's borderline diabetic. He does have some sensitivities, mucosal sensitivity from Sensodyne and some fluorides. Doesn't have a decay problem. As you can see on his x-rays here, there's no history of decay. However, even with his meticulous care, he has severe bleeding at all of his dental cleanings. He always has heavy interdental plaque, buildup, stain, tartar. He's that patient that we all are like, oh boy, here we go, right? 5 to 7 millimeter pockets. He's constantly having episodic moments of periodontal abscessing. As you can see on his x-rays here, he's got areas that are up to 50% bone loss. So chronic, moderate, advanced periodontitis. And the interesting thing that he kind of shared with us as we were putting this case together was he was complaining of water blisters he was describing as like popping and oozing this watery substance in the extracted areas by his wisdom teeth. He started his journey in 2014 with the start of some scaling and root planing. 2017, the typical cycle, we're at our 3-year, 5-year mark where we're always recycling the scaling and root planing process. Well, he did in 2017, he did his first non-bristle salivary test. And if you look to the side here, there's really nothing significant when it comes to the major pathology. We have your red complex, your orange complex, your green complex. We have Fusobacterium, which I can tell you I see in most oral microbiome tests that I get to see within patients that we see within Bristle and even with my practice. Fusobacterium is pretty common in almost everybody. And then P. micros. But overall, where's the inflammation coming from? If he has bleeding and he's constantly in this cycle of treatment and scaling and root planing, where is the inflammation coming from? This man has been through scaling and root planing, perio specialist after perio specialist, 4 referrals in 4 years. Let's just look at his perio charting for a second. And this tells a little bit of the story. Starting in 2017, you can see here that he has, up to those 7 millimeter pockets, pretty significant clinical attachment loss with the recession areas. Over time, yeah, it looks like he has improved, but also he has symptoms in 2021 still of having bleeding, major calc, major staining, and those water blisters that keep popping up. So he's still in a highly inflammatory state, even though his peri chart is showing that he's had improvement. So in 2021, in November, his doctor decided to run a Bristle test. And the first thing that I want to show, I love, we didn't really talk about the platform here, and I'm not sure how many of you are utilizing the Bristle test, but we have the conditions related. We have the halitosis score, the gum inflammation, tooth decay, the gut impact score. We include the commensals, the diversity, and the nitrate. Those are all super important areas to really consider. This doesn't look too bad when you look at it initially. The gum inflammation score is low. However, this was before we realized at Bristle that there were some opportunistic bacteria that were driving people's inflammation scores. So the big thing on that score is he had very low, no diversity, and very low commensals. We still needed to dive deep into the situation. The other part of the platform that we have is we can go into the raw results and really look at what's going on in this patient. So when you go into the raw results of your platform, we can click on detected, and that gives us a relative abundance. Now, what's relative abundance? Relative abundance is the percentage of that pathology within your mouth. So every relationship within the mouth, all of those bacteria can add up to 100%. So if you look here, his relative abundance was 78% of this Serratia bacteria. 78% of his oral microbiome was occupied by this opportunistic bacteria, which was crazy, right? Like, this is what happens over time when we keep bombing out the oral microbiome. And this is why I like talking about, you know, making sure that we're catering and promoting healthy bacteria, because a lot of times what we're using in the mouth causes this imbalance. And I see this all the time on the test results as an oral health coach for Bristle. Relative abundance is super important. We want to have a wide variety, and we don't want to have pathology at these types of levels. He scores a 10 out of 10 in this category. How we get the percentage for that is, this is 10 out of 10 is 100% of the general population. So he scores at 100% of the general population. That's how we get those scores there. So we found the problem, right? It's Serratia. So this doctor got innovative, because how do we treat Serratia? It's not a bacteria that we really have heard too much about. And how do we know what to do? So she spent the time to refer to an immunologist and a infectious disease doctor. She did do an initial treatment of putting the patient on a chlorhexidine rinse of vitamin C and a probiotic, and sent them to these specialists. They did a boatload of tests, took a bunch of vials of blood, and found that he didn't have any systemic issues or infections that were problematic. So the treatment was continue on your Paradex, your vitamin C, take some oral probiotics, maybe a systemic probiotic, and continue with your routine. So it was a dead end for this patient. So in July, we did a couple of different tests, and in July he still wasn't having good luck with getting symptom relief. So we did another test in July, and in July he was still at 60.9%. So the halitosis score was high, our inflammation score was high. By July, we had finally incorporated the Serratia into the category of gum inflammation. But look at our commensal and our diversity, still incredibly low. So we had to go back to the drawing board and try to figure out, how do we treat Serratia? So in July, there we go. We started to do a little bit of research, and our scientist and guru, David Lynn, sent some information to the office to help them through the Serratia process. So Serratia marsans isolates in the subgingival biofilm. So it's a bacteria that's along the gum line. It's causing that inflammatory response. It's causing the bone loss in this person's mouth, right? So how do we treat it? Xylitol inhibits the growth and blocks the virulence of strep mutans. So it does this by inhibiting the biofilm formation. It's going to reduce the fermentation process and block protease activity. It also, we find, helps with the swimming and the swarming motility, bringing that down and making that Serratia more susceptible to hydrogen peroxide. Xylitol helps to downregulate the virulence. That's super important. So we went ahead and revised the treatment plan process. So brushing still 3 times a day after each meal. He initially started using xylitol mints several times a day. This caused the typical bloating that xylitol can do. So he went ahead and switched himself to doing half a teaspoon in the mouth with warm water, letting it dissolve, and then gargling it for several minutes. So he made his own homemade remedy of xylitol. This reduced the ingestion process and, reduces bloating and bowel irritation that xylitol can cause. He started taking oral probiotics heavy in Lactobacillus rudii. He started brushing with Boca twice a day. This helped with some sensitivity issues, but also he was just having some major issues with Sensodyne, so that reduced some of his oral sensitivity to that. Before bedtime, he incorporated intradental cleaners, used a tongue scraper, incorporates warm water in his water pick, and I think this is super fascinating. He also took the extra step to make sure that he was disinfecting his oral appliances, and I think that's something we really need to consider. Are we just re-inoculating ourselves with the products, or our interdental cleaners, are they clean? Is the mouth guard that we're putting in each night, is it clean? So he was making sure that he wasn't cross-contaminating himself. He really monitored the water intake and made sure he was boiling his water to reduce any infection that way. Serratia is one of those bacteria you can pick up from surfaces. It's one of the more common ones in like hospitals. So it's a common bacteria that causes that pink biofilm that you see in the bathroom. So he also increased fermented foods like kefir. So let's see how this helped him over a time period. So this is a really cool time period process. So his first initial test, November of 2021, he went on chlorhexidine for 2 months. At that time, he was having those little white blisters at the back of his, wisdom tooth area, and he was getting them about once every 1 or 2 months. In February, there was another test. It looked like maybe the chlorhexidine had inched it down just a little bit, so maybe we were headed in the right direction, but we're still not getting relief on the bleeding, the heavy plaque, the staining. So in July, go back, please. Thanks. In July, he does another test. Serratia's back at 61%. And that's when we decided to give him the new and do a little more investigating. He started the xylitol mints 3 times a day, switched to the xylitol rinse and the Lactobacillus rudii, and look at the difference. By October, we had reached 0. At that 0 point, we had started to reduce his abscessing issue. And since October, he hasn't had any abscesses that he can remember. But the other correlation that I think is really important is he no longer has bleeding during his cleanings, and he no longer has interdental plaque, calc, or staining since we've eliminated the serratia level. So that's pretty profound. And I want to just walk you through how xylitol also helped his inflammation and commensals. So this is a graph here, and it shows how the xylitol helped to stabilize the oral microbiome over time. So in November of 2021, like I said, we didn't have serratia in our test scores where it would impact the inflammation score. We know through his symptoms that he was probably still at that 9.9. So, and notice his inflammation scores tend to be high when our commensals are low, our beneficial bacteria, right? So in July, there's a large dip in what took place. So once we incorporated the xylitol, not only did we decrease the serratia, we were able to use that to really promote the healthy bacteria in his mouth. And as his commensals went up, his inflammatory scores went down. So this is why it's so very important to understand the whole picture. Everything is it's a polymicrobial environment in our mouth. And we really need to understand the relationships and what products will help drive health in our patients, reduce inflammation, increase those commensal bacteria, and promote health in our patients. And it's really, the chlorhexidine is one of the bombers. Oftentimes in some of the tests that I see, you know, there's certain products that I will always see, I can make guesses on what they're using based on the score being high inflammatory, low nitrates, low commensals. So it's time for us to really stop thinking, you know, on a scale of just kill everything, because we really can show here that if we focus on promoting healthy bacteria, we're going to counteract our inflammatory bacteria. So I just want to share a couple quotes from this office. The doctor made some really cool inferences here. Long-lasting health is not achieved by crazy procedures or techniques. It's oftentimes habit and lifestyle modifications. So even though this patient was doing everything that he knew how, and the doctor and most of us try and have intentions on doing it, we needed to start looking at specific bacteria and targeting that specific bacteria, bringing it down, and really focus on seeding the healthy bacteria in the mouth and getting that homeostatic phase, right? She quoted, practicing on the bleeding edge. Using our Bristle test will help us develop new techniques in applying those techniques by testing and retesting. It's a learning process for all of us, and we really need to start learning what works in the mouth, what's helping our patients achieve better goals. Bristle tests helped guide our efforts because the radiographic bone levels and periochardin couldn't capture exactly what was happening as clearly and as quickly as his oral microbiome shifts did. I think this is a pretty amazing story. So, Kriston, I'll let you cover the next one.
All righty. Great job. Love that story. Here's we all have those individuals in our practice that don't want to move forward with anything. So Bristle made this individual change their mind. So that's why I thought he was great to put in there for an example. He's a 75-year-old male. He's got a history of decay and gum disease, and every hygienist who have seen him have tried desperately to get him to do some gum disease treatment, something to help him with his process. And he was steadfast in not wanting to move forward. Well, he's a diabetic. He's taken 2 meds, high cholesterol, asthma, head and neck injuries, and he has viral infection or cold sores. First of all, when you look at diabetic, high cholesterol, asthma, start thinking airway. You see that on the medical history. Head and neck injuries, well, he might not be able to move as well. Viral infections and cold sores. Viruses will excite that bacteria. They work hand in hand. They kind of make them more virulent. So watch that in your patients too, because they're cyclical. So they might be doing fine bacteria-wise, and then all of a sudden they'll have a jump in their bacteria or how their condition looks. Here he is. He's got numerous restorations. He's got 2 to 4 millimeter pocketing, bleeding upon probing, furcation involvement. Clinical attachment level is 2 to 5 millimeters. Please look at your clinical attachment levels. We all take the readings. We might say 2 to 3 millimeters, no biggie. But what if he's got 5 millimeters of recession? You take a 5 millimeter recession, add that to 2 millimeter pocket, that's 7 millimeters of attachment he's lost. Can he afford to have any inflammation just in that element? No, he can't. So start looking in those regards. Here he is. Yes, this dentist actually took over a practice from a previous dentist, and this previous dentist believed in kind of patch and fill. So his mindset of the people that he saw was patch and fill. Unless it hurts, don't do anything. So you have to get past that psychological element too when you're talking to your patients. So he did go ahead and he had the Bristle test done. Here, I want you to kind of look at the picture though, as you see all those numerous restorations, endodontic lesions. 78% of the time when they pulled out a clot, Pessy pulled out a clot in a person who was in the midst of having a heart attack, 78% of the time it was strep viridans, tooth decay found in those clots. And 35% of the time it was from periodontal pathogens. So we need to, again, know what we're dealing with so that we can take better care of our patients. He's already has high cholesterol, so that means bacteria is allowing that cholesterol molecule to get into that endothelial lining. It takes 2 failures of an endothelial lining for a person to have an event. What I mean by that is inflammation. Inflammation caused from anything, but inflammation, think about it, our gum disease, chronic inflammation causes that endothelial lining to break down, allows material to come in, bacteria to come in, and start that whole plaque process. So it's down below there, you got plaque starting to build up and it's silent. You don't know what's happening. The second time you have an influx of inflammation, maybe it's actually, you do a deep cleaning. You put a bunch of bacteria into that patient's mouth, into that, from that patient's mouth into the bloodstream. What happens? That second inflammatory process can make that endothelial let loose, and that plaque comes out. And where that plaque lands is its clinical name. If it lands in the brain, we call it a stroke. If it lands in the heart, we call it a heart attack. Those bacteria cause the event and even help that plaque pull out. So look at all these things with your patients. Here he is. What are we seeing here? We have very, very narrow palates, narrow arches actually altogether. We have crowding in the anteriors. He can't even take his tongue and touch it to his roof of his mouth. He's got a tongue tie. He actually has on the far right a submucosal tongue tie as well. He has a Mallampati score of 4. That means he has no airway. He can't lay on his back because if he does, he doesn't get enough oxygen. He's got to lean to the side or on his stomach. He's got an airway issue as well, so breathing. He should be seen with a medical doctor for actually a test or a home sleep test for those of you who have that in your practice. This individual has inflammation also from not getting enough oxygen. Not enough oxygen to his cells are going to make them die. And when they die, the organs die. And again, eventually he will have a poor quality of life and short-lived. So here's his test. We got him to do his test. Look at that. Lot of halitosis, gum inflammation, tooth decay, and gut impact. His commensals are moderate. Diversity, you want diversity. It has to be diverse. Wherever you find that there is no diversity, it's been linked to disease and health conditions. When you look at his medical issue, you can actually take his medical history and look at this bacterial form. 6 bacteria related to gum disease. We know he's got a history of gum disease. 3 bacteria for diabetes, taking 2 meds for diabetes. Cardiovascular disease, he's on a statin. 4 of those bacteria are contributing to cardiovascular disease. And here's interesting, various cancers, 3 of them, biomarkers. Question is, if you continue to do his testing, are you going to find these increase in number? Very important to watch. So what we did with him, we had to discuss his health conditions and how he was doing, his status. We had to look at his oral condition as well. We had to discuss what was going on. And we recommended the dental office recommend our treatment and also the Bristle testing. He went ahead and did the Bristle testing. And because of that Bristle testing, he said, oh my God, there's an issue here. It changed his thinking process. How great is that? You can turn those individuals that are skeptics, that are kind of naysayers, into believers. We went through his therapy, and for time's sake, I'm just going to hit on that we did his gum disease treatment, laser decontamination. We put some ozonated olive oil in there. We did, again, activated that laser and did some activated. He's going to do closest 2 times per day, flossing at least 1 time per day, but we know that cardiovascular wise, if you floss twice a day, there's studies that show that it helps cardiovascular wise. Tongue scraping, he felt his diet was significant. It was just sufficient. And he did not need his probiotics that we were recommended through the Bristle care plan. So again, you meet your patients where they're at, because give them an opportunity, build that relationship, because that's what's going to bring him forward. Well, here's what he looked like. It looks pretty good. He's got still the moderate and diverse. Nitrates are high, which is great for his vascular situation. His halitosis, bad breath is done down. Gut inflammation's low. Decay is still there, so we still have more room to work, and his gut impact was low. So did we make a difference? Was this considered a success? Yes, it is, right? But even when you have success, you always have to monitor. Did your treatment get you where you are? Yes, it did. But is it maintained? And if it's not maintained, why? Well, here he is. Looks good. Look what happened. Well, he went ahead and we gave him the Periprotect trays because we thought he could put his fluoride in there and wear them about 20 minutes. at least once a week. So we thought that was good. However, he didn't do what he normally did with his home care. He all of a sudden thought it was like if you had the PeriProtect trays, he didn't have to do everything else. PeriProtect trays are dealing with the environment below the gums. It doesn't look at the whole oral cavity. So there could be lots of dysbiosis going on everywhere else besides in that sulcus. So unfortunately, he had some depression. And again, his gut impact is high again, right? Serotonin, 90%, dopamine, 50% are synthesized within that gut. He wasn't taking good care of himself. What happens? You don't eat right. You don't take care of your mouth. All of these things, psychologically, you have to deal with this. Also, when you look at sleep apnea, airway issues, not getting enough oxygen and how it deprives cognitively, you have to put it all together for this individual. And sometimes you start back at square one. Okay, now let's look what we're supposed to do. Now let's think about doing those probiotics. Let's see what we need to do to get you healthy. This is an airway issue. You're going to be combating that back and forth. You're also going to be combating his viral co-source, things like that. So look at your patient, realize you must test and retest. Don't be afraid to retest the patient if you see activity in their mouth. And then this is an opportunity. It is not a failure by all means when you see things change, because we know those opportunistic bacteria they'll jump at a moment. If your immune system is not robust, and stress is the #1 attacker of that immune system, and those opportunistic bacteria, they'll jump on it. And when they do, they'll overpopulate, push out your good. Super beets for his nitrates. We want some as basic bites for arginine. So we got a chance. And then of course the xylitol, caries prevention. All this we can add, but make that patient understand and make them not feel ashamed of where they are, but just give them encouragement as you move them forward. Because we know that you can do your best until you know better. Once you know better, you can do better and offer better things for that patient, as long as you make them feel good about themselves and don't make them feel bad. We're working together as a team to get you healthy. So here is my patient when we're going to go into sleep. This patient, some of you have seen this as a past presentation: chronic fatigue, depression, mood swings, headaches, and mouth breather. And of course, he has cardiovascular disease, depression, and periodontal disease in the family. This is an individual who has sleep apnea. He wears a CPAP machine. Now you got to know whether it's nasal or full mask. His is a full mask, so it's going to change the environment in his microbiome. This is what do you see? We're going to hit on this again for time's sake real fast here. He's got numerous restoration. He's got endodontic lesions. He is clenching and gripping those teeth down to nubs. He has crowded anteriors. His curve of SPE is changed. Endodontic lesions present. Remember, we just got done saying 78% of the time you pull out a clot, it's got those bacteria that cause endodontic lesions. He's got asymptomatic. We use the SoPro camera, which showed inflammation. So you can see the inflammation in his mouth. We went and sent him off for blood workup. The blood workup showed that he is vitamin D deficient, omega-3 deficient, and his glucose was about 94. He's creeping up there for prediabetes. We did at the time the bacteria test that was available. He's got a significant infection. From there, we also went ahead and did a carotid intermediate thickness test. It's a B-mode ultrasound. It was approved by American Heart Association in 2000. Many years, 24 years ago, going on 24, but we don't do this test. It looks for the plaque within the arterial wall. 99% of the plaque grows away from the lumen. The lumen is the hole where the blood goes through. So if you got plaque inside that hole, just imagine what's outside of it in the intermedia. That silent plaque that grows away from that hole is the most dangerous. That can pop out. We did his test. He's 53 years old and his arterial age is 85. Houston, we got a problem here. We have a big problem here. He's ready to blow a cork, basically. He's got all these inflammatory bacteria. Look at his periodontal charting. Now, let me ask you this, 2 to 4 millimeters with a lot of bleeding. How many of you would have said, oh, well, insurance won't pay for that? We're not going to do anything. Maybe see you back. Maybe we'll shorten you up to 4 months. We need to know what's going on. We got to stop treating the patient by what insurance says, but the disease we see in front of us. We need to test to understand the disease process in front of us. And again, we went through the treatment. We used, again, we did biofilm disruption, we did the laser, we did ozone oil, ozone gas. We used a series of piezo tips on this individual. Saw him back 6 weeks later. We did another test because you always want to see, did your work happen to, did your treatment work? Then from there, we did the myofunctional therapy, put him on a diet regime. Basically, we wanted to increase his vitamin Ds, get his omega-3s up and vitamin Bs. Monitor his CPAP pressure because we wanted to make sure that it was where it needed to be. And then did he want to do restorative treatment? Got the endodontic lesions taken care of. He didn't want to do orthodontic surgery or ortho, so we kept him on a 3-month schedule. This is what he looked like. So yes, we did have success at that time. He declined periprotect trays at the time. He didn't agree to come in and shorten recare. We got his pressure from a CPAP down and his AHI down. You can get 50% reduction in CPAP pressure and AHI by doing myofunctional therapy. So you can do a lot for your patients, a lot of treatment, and he looks great, right? Well, then along came COVID. What happens when COVID came? Lots of things changed. People didn't come up for their cleanings. They couldn't get out. They couldn't eat properly. They ate what they could. They were stressed. All these things attack that immune system. And when that immune system isn't where it's going to be, what's going to happen? Those bacteria are going to play. They're going to play hard. So this is what he looked like. Low commensals, low diversity, inflammation. Halitosis was high. He had Klebsiella, right? Volatile sulfur. Lots of things going on, and gut inflammation. Lots of things. So we did his treatment, and here he is, looking much better. But he still had some gut inflammation we want to work on. Untreated cavities that were breaking down, harboring bacteria. We recommended basic bites, arginine. We needed to look at his diet again and his probiotics. There are opportunistic bacteria that once you kind of cut some bacteria down, you've got to get a chance and you have to regrow the good bacteria. Stress, quite a bit of stress in his lifestyle. That's what he said happened. He was eating sugar, not eating properly, so his diet changed, gut impact. All of this changes what's happening with that individual. Look for things. Sit down and talk with them, find out where they are. This shows you the difference, which is great to look at because it's important to test and retest, and this is why. You think you're doing great with that patient, and then a life-changing event can happen, and then the bacteria change. You need to keep a real close tether on your patients, especially if they have a lot of comorbidities, because you've got to help them through this process. So realize it's collaborative care, optimal care, review those medical histories, educate and inspire your patients, do your screenings, do your salivary testing, get the whole picture of your patient's health. Because if you're not doing it, then who? So you really have to work with your patients. Me and Heather are very happy to present this information to you so you realize that it's the whole picture. Heather did a beautiful job of looking at the garden. We have to feed the right things to our garden, make it grow to stay healthy. Otherwise, it will die. And unfortunately, we don't want to see our patients dying. So we're going to pass this off to Danny.
First of all, thank you both so much for the presentation. If we weren't on Zoom, I mean, big round of applause for you guys. This was so informative. And, you know, I love how the title ties into so many of the themes that you guys covered, right? Uncovering new pathologies in patients that are expressing really severe symptoms and feeling like they have no route to recovery. You know, digging deeper into the patient's medical history to really get the full picture of what's going on and correlating that with the oral microbiome results. I think one of the things that we talk about as a team is just how much the data can be a tool in all of these different kinds of situations for providers, dentists, hygienists, other kinds of specialists to really help their patients. And, you know, what we want to promote is oral microbiome testing, but really root cause care. Right, and personalizing and optimizing that patient experience to make them, one, successful in achieving their health goals, but also create a really deep and lasting relationship between the patients and providers. And the case studies that you guys presented, I think, spoke to all of that so well. So thank you again. I am going to finish up with some of the more mundane information, but I did want to touch on just how to get in touch with our team for anybody who's interested in implementing testing, or if you already have Bristle tests and you want to go back through some of these case studies, talk to either Kriston or Heather. We can certainly work and coordinate with them to make them available. So for those of you new to Bristle, if you want to join, you can schedule your onboarding and training call. Either go to the website that I included, or you can contact our team directly through provider support at bristlehealth.com, and we'll be sending out this recording, so the information will be there. The next step, just create your office account and order your first kits. We charge $15 per kit just for the materials, and then we bill you monthly based on the number of samples that you use. So it's a pay-as-you-go model. And after that, you'll be ready to start testing and really transform your care. We have and develop new resources, support, and trainings all of the time. Like I said, this is what we plan to be the first of many webinars and kind of study clubs around how our test is being used. And practices that join Bristle also get listed in our dental directory, which we use for new patient referrals through our coaches, our website, and obviously through the practices themselves. And we are going to shift to the Q&A after a final thank you to the audience for joining. So the first question, and we got to some of these, but I'll post them again for Heather and Kriston to answer. I believe both of you touched on using pH strips. So we have a question just around what pH strips you recommend using to check salivary pH, and how and when do you use those in practice?
We order on Amazon. We have a basic pH strip. The first thing that my patients do when they come in the chair, I have my slide information. I have them spit in a little medicine cup and we take a pH. I'm actually switching to my fit strip because we're not assessing nitric oxide at this time, and I think that's a vital part of the oral microbiome as well. So we're gonna do the MyFit strip that has the nitric oxide and the pH strip. So it's the very first assessment that I take on my patients after doing health history information. And then I do my microscope slide.
Perfect. Let's see. We have a question. So we stated that Bristle is testing for over 700 different types of bacteria. What is the average number of bacteria found in patients, and is there an optimal number that should be present? Do either of you want to maybe speak to the average number that you see in our test? I know that from my personal experience, I believe it's somewhere between 100 and 150 different species, maybe. And obviously in the case study that you presented, Heather, that was on the opposite end of the spectrum, with really just a handful making up the entire oral microbiome community.
Yeah, I would say, yeah, probably between 100, anywhere between, depending on low can be like in the 50s, all the way up to about 150 are generally what I'm seeing on most of the tests that I'm going through with most of the clients.
Got it. And a question for both of you, and maybe you could speak to one or two kind of primary situations around this, but what kind of patients do you retest, and at what cadence do you recommend retesting?
I would say for me, I set it up so that they're tested at least between 6 to 8 weeks after. And then depending on if there's a life situation, a surgery, death in the family, any crisis, I'm going to retest. If I'm looking in the mouth and they've been doing great and their test prior said they were doing right, all of a sudden I see bleeding, any sign of bleeding says that process is starting, that the shift has occurred. So I'm going to test because the patient wants to have optimal care. So it's just like when you have blood pressure taken, and your blood pressure is high. Well, they're going to try a different medication if the first one's not, or they're going to adjust. So you have to test to find out where you are. So I have no problems with doing it at that cadence right after therapy. Definitely at least yearly. If they're healthy, they're doing well and nothing's wrong. I like to say twice a year. but at the bare minimum, I will do once, but they don't have any comorbidities on their medical history or family history if it's once a year. But other than that, more often than not.
Yeah.
That's awesome. Thank you.
And then
Heather?
for my office, I have a couple patients that were doing ozone therapy tray treatment, and I'm waiting about 3 weeks after their last initial therapy treatment before, just to make sure that, you know, they're kind of, I'm not testing the ozone treatment right away. I have a few patients who don't necessarily do their test immediately during the guided biofilm therapy that I might be providing. So I always wait about 3 weeks for them to do that. And then I encourage, like, do your treatments and then test to see if your treatment worked. I think that's super important. And I learned that value with the using the microscope as well, because I've had cases where you think that you're doing a stellar job, and then, you know, you do another microscope slide and all of a sudden, you know, things are worse. So I usually do a 4 to 6 week eval. That would be probably when I would do that if I'm not doing my slides, or if I see something crazy on my slides, then I would definitely make a recommendation for a retest at that point. So I think everybody is valued at doing a test. Sometimes you have patients who look like they have pink stippled firm, beautiful tissue, and you'll be really surprised as to what the scores come out to. Just because someone's not presenting with inflammatory response in the mouth doesn't mean that the oral pathology isn't high. So
That's
yeah.
a good point, Heather. That's a good point you made. I had a patient that came from Dr. Amy Doneen, and they do all the cardiovascular workups and that. She wants to make sure those patients are healthy orally. I looked at his mouth. I took the probe. I might have had maybe 2 or 3 bleeding spots, maybe 1 or 2 4 millimeters, which normally would have been see you back in 6 months in today's world. I did the saliva test, and he was high on the high risk. I didn't have the opportunity to do Bristle to find out what was going on with the whole process, but that just goes to show you that, you don't know what's going on underneath. You can't see what you can't see.
And that's really the preventative foundation of salivary testing, because we can address the cascades of inflammation before they're presenting in the mouth. That's the model of preventative dentistry. Let's prevent the inflammatory cascade, knowing where the pathology is there, and actually being actionable before disease processes happen. So I think this should be a standard of care in general.
Well, it's 7 o'clock and I could not have said it better myself. So we'll end it here. Thank you all for joining. We have more questions, and what we'll do is we will answer these offline, and we'll send an email out to all of the attendees that includes the link where you can access the questions and read through the answers. Like I said, if there's any follow-up questions, if there's any comments, feedback, requests for topics that you'd like us to touch on in the future, feel free to email our team at the same place where you can reach out for interest around learning more about the test, provider support at bristlehealth.com, or you can go to our website, bristlehealth.com, and just click for providers at the top. Thank you all for joining. Thank you, Heather and Kriston, for hosting and sharing all of your knowledge and experience with the test. And see you all next time.
Thanks everybody for coming.
Thank you.
Bye, everybody.